Live on YouTube, I can see it.
Okay.
Excellent. Live on YouTube, I can see it as well.
All right, I'm going to change you back to Donna. Host, once I get out of there.
And we don't normally make the captioner a co-host. We just assign them the caption. Is that your
Correct.
recollection as well? Yep.
Yeah, unless they have to spotlight, but that's just, yeah, for the ASL.
Yeah, for ASL. Exactly right.
Okay.
All right, I have nothing up on the big screens in here. Should I or not?
Stand by. Oh, I need to redial that room from here. Yep. Thank you.
Okay, Donna, I've made you the host. If you could make me a co-host. Great, thank you. And right now, Donna, you're showing, well, okay, it's on, it's going back and forth, whoever's going to the host on YouTube.
So Donna, while I'm sharing my screen, I can't see the waiting room or anything like that.
Correct. That is as per design. So she'll be watching that. If you do want to look at it while you're waiting, if you go up to participants, it'll pop up kind of like right there.
Gotcha.
Yeah, I've got it. Maria Stronsky is in the waiting room right now. She's the only one in there.
All right.
So
Okay,
what
well,
was
now
that?
I can see, and you decide whenever you want to start letting people in. We'll just be aware. Let's keep them muted when they come in, Donna, and then you and I'll just be careful about any conversation that we have.
All right.
On the headquarters, why is that admitted?
That's the main room that I'm sitting in.
Oh, okay. Did you just do that, David?
What's that?
It put the headquarters in there, or okay?
Yep. Yeah, because that had disconnected too. That's why she couldn't see in here. So.
Oh, okay.
I'm putting a big post-it on top of my monitor that says disable
Encryption, yeah. That's number one on our protocol thing.
It is.
Okay, so Communique is still having trouble and can't see captions on her screen.
Well, are you split screen or, no, I mean, that shouldn't make a difference how you're, well, if you have two monitors.
I'm gonna say, look at bottom.
Does she have the show subtitles?
I'm gonna say, look at bottom of screen under more or three dots.
Yeah, I was gonna say, I'm trying to take a screenshot of it, but it won't stay where you.
It does not.
Yeah. Icons for caption.
She says, I know where to look, it's not there.
Do you have to be you don't have to be a co-host, but no, every participant, is there a setting, David, where you said allow every participant to?
I'll make her a co-host as Communique, see if that fixes it.
Just so, yeah.
Stand by.
Just to test.
Just to test that. One. Participants. Okay, or make co-host. I can't make co-host, only the host can. So Donna, you're gonna need to make Communique co-host.
Just so she can see if she can find the captioning.
Done.
All right.
Okay.
And
so Marguerite, see if you can find it. And
now chat. Not there. Enable subtitles for everyone.
Ah.
That's what she says. She needs to do that. I'm trying to, well, I'm not host, so I can't do that anymore. Donna, can you make me host for one more minute, please?
That's what I was thinking, that there might be a.
Are you Zoom one?
I am Zoom one, please. Yes. And I'll make you co-host immediately. Yep. right, I'm looking real quick.
Oh, I didn't know you could chat to people in the waiting room. That's cool.
Yes, you can. There is no setting for me to enable subtitles for everyone.
Huh.
And everybody else is able to see it.
Well, let's see if any other participants, when you admit them, when you
I'm
tell.
going to make the captioner also a co-host just in case that kicks it. I mean, I'll try anything at this point. There we go. All right, so I'm going to go back and make Donna the host. And Donna, you can make me co-host, please.
It's probably always a good idea to have the captioner be a co-host because, like you said, if she gets disconnected when she
Right.
logs in, she'd automatically be back in, or in case somebody locks it. I don't know.
Yep, something.
Well,
all right, so Donna is the host. Can you make me a co-host, Donna? Zoom one.
Hold on.
Yep.
although if you lock the meeting, David, you said no one can get back in, even if you
Yeah,
already.
I'm not locking board meetings right now. I'm making an executive
Okay.
decision for not doing that. They can come get me later.
Okay. What's the little green arrow? Like Christian. Yes.
That means I'm sharing my screen.
Oh, cool. Okay. I learned something every time I'm on Zoom.
Yeah. All right, let's look back at chat.
Did you let Maria in?
Oh,
I'm here.
I didn't.
Hi, Maria.
Hi.
All right, we're just talking through some technical stuff for a minute. You're the only one in here. Welcome.
Oh, party. No worries.
All right, Maria, we're going to keep you on mute. Yeah.
Craig is connecting. That's good.
Nick Redisil is in the waiting room. Now he's not anymore. Who's letting him in?
Is it because the meeting is unlocked that people can just come in?
Well, the meeting's not unlocked. Right? That's a global admin, right, David? I mean,
What's that?
no one. They have to be let in, right? Everybody, because people are just.
Everyone has to be let in. That is a security setting. You can't just come in without coming into the waiting room.
Well, people are
Well,
just
who's
entering.
letting,
I'm sorry.
I don't know.
who's
Not me.
letting in right? It's not me.
Is that because the meeting is not locked?
I
No,
don't
it shouldn't have to
understand the
do.
question.
Well, people are coming in from the waiting room without being officially let in.
I'm not sure how that's happening unless somebody else is admitting them. Any co-host.
Well, we're
can
the only
admit people. We have many co-hosts, so.
Yeah, why don't we, if you want to undo.
Only the host can do that at this point, so.
Right.
All right, so Barbara Seymour's in the waiting room.
So Donna, if you want to admit her, that would be your role if nobody else is doing it.
Wanted to see if somebody else was letting her in.
Okay. Look at you.
Who is the culprit?
Yeah, because I didn't do it, but okay. I'll let her in. Can I go ahead and start the recording now too?
Yes, ma'am, you may. And when the meeting is over, you want to leave your computer running while it compresses. Do not turn off your
Right.
computer. Yep.
Right, no problem.
Hey, David,
Yes.
where do you see that there are people who are in the waiting room?
So you are not a
I've got it.
co-host, so you will not see it. So Donna, if you want to make Craig a co-host, he could also view it to see how this happens because he's going to be Betsy's backup.
I wondered why you were here, Craig.
Me too. Yeah, I'm trying to learn how this live streaming part of it works.
I've already done that, but just so you know, as a backup to me, David has to take off the security, the encryption
Yep.
before that happens. So if there, for some reason, whatever, that happens again, just note that, yeah.
Just say, David, you forgot to unencrypt the meeting, which will never happen again.
No, but I mean, yeah, or if it could be one of your coworkers or something, but yeah, that has to
Absolutely.
happen.
Yeah,
They have to first take encryption
If
off.
YouTube is missing from your menu, Craig, that is what's up. It's still encrypted.
Yeah. Because that's the
Thanks,
default.
Marguerite, for calling me.
Okay.
Okay.
So we don't have anybody in the waiting room. I'm sorry about the subtitle challenges. It is enabled as an admin within Zoom. We will look at that after the fact today. We have another meeting on Monday as well. I think everyone else can see subtitles, unfortunately.
Well, you're going to say that as part of your intro, right? The Zoom housekeeping.
About including the status, if you want to see the captioning, yes.
Yeah. Okay.
Perfect. All right, at this point, I think we're getting close to time, so I am going to mute myself.
Me too.
One quick clarification, we do not have ASL here, so we could spotlight Chris Miller as the primary. Is that correct?
Oh, you don't need to do that.
Okay, fair enough.
Welcome to Zoom. Enter your meeting ID followed by pound.
I've unmuted Donna.
Hello? Hello? Hi,
Hello.
this is Sandy. Oh. This is Barbara Seymour. Hi, Barbara. Hi.
This is John Heath.
Hi, folks. We're still waiting for people to come in, and then we'll be starting things off, hopefully in the next 5 to 10 minutes. Yeah. I'm going to send you, I want to make sure that you have the right link information. Okay, I wonder. Okay. Then you're in the wrong meeting. So I'm going to forward this.
Chris, can you hear me now?
I can.
It's the craziest thing. Yeah, it's Donna.
So Kevin just came down and said that he and Carolyn cannot get in.
They're not in the waiting room.
I'm sending them what we just sent. Wondering if that's why Anne and Monique and Cara are not here.
Is Betsy still here? There she is.
Yeah, I am. So yeah, Chris, I would resend them the Zoom email it, because you said that it's possible they got maybe they got the old link if you had a previous meeting set up. I know there's a way to do it from Zoom, but.
Marcia.
Oh, here's
And
Carolyn.
Betsy, just so you know, Communique identified a way to solve the issue for themselves, passed it along to me, and I've made notes on it, so we can incorporate it that next week.
I spoke with Marguerite, so we're good.
Did you speak to her after I just spoke to her?
I think so, yeah. She tried to call me. My phone was, I didn't answer my phone. I didn't have it in front of me.
Who is the 804? Uh-oh, hold on. Anne might be having the wrong name. I don't know who's letting people into the room because I'm not doing it.
I've let some people in.
Okay.
Donna, are you not able to connect with computer audio? Is that what you would try to do?
Yeah, when I put everything on hold to go take that call from Marguerite, I couldn't get back in. Nothing I did would work, so I just called in on my phone.
Okay. Do you have earbuds you could connect to? It might be easier than having to hold your phone.
Oh, no, I won't be talking, actually, once the meeting starts, so I'll just be listening. Who's the 757921 number?
Hi, if you're calling us from the 757 area code, I just unmuted you. Can you let us know your name?
I think that's me, Chris. This is Kevin Kojal, Director of Independent Living from DARS. And Chris, I just wanted to let you know, Gail Brunk did not have the correct link either. So I'm gonna forward her that email if that's okay.
Thank you very much, Kevin.
This is strange because I didn't send that link out to anybody.
Nope.
It's the one when we accepted the meeting. If you click on your Outlook invite, that's what we're all being sent to.
Yeah.
As a different password number and everything.
Yep. And Donna, just so you know, I've been letting a few people in.
Okay. Is Monique one of them?
Was Monique one of them? No, Monique's not here yet. Okay, Cara's letting me know that she is not getting in either, so I'm sending her and Monique.
I just got in.
Oh,
other Cara. Sorry.
Yeah.
I was like, hey, I'm here. I just muted myself.
Hello, Nick Redisil.
Hi, Nick.
Hi, is Hoyt mute?
So folks, thank you all for waiting. We have obviously had a little trouble with some people got wrong links, and within the next 5 minutes, we're going to get ready and start the meeting.
Oh, Monique's in the waiting room. She's coming in.
Wonderful.
And so is Cara Meixner.
Elizabeth just showed up.
I've got you. Thank you. George Worthington's here.
Yep.
Marcia. Jason's coming in.
Hi, this is Susan Moon.
Hi, Susan.
So I apologize to the larger group. You don't even need the details. Technology.
We're having technology too.
Oh, good.
Hey, everyone.
Not good, but.
Sorry I'm late. I guess there was 2 links for this and I was on the other one, which is really boring.
Hi, everyone. I got caught up in the wrong link too.
Don't worry, everyone. Don't worry.
So did Chris and I.
So, hi, folks. This is Chris Miller, Director of the Brain Injury Services Unit, and I want to say thank you to you all for being here today. And our apologies for trying to send you on that little scavenger hunt with the wrong link. So we appreciate you bearing with us. The primary focus of today's meeting is going to be talking about the recommendations, the priority recommendations that will go to the commissioner to consider for DARS and their brain injury services. And I want to thank you all for your participation in helping us to do that, as well as to the committee. And we'll get on, we'll hear a little bit more about and from them later on. And I'm going to be turning this over to your chair, Monique Wilson, in just one moment, and we'll get started. Just want to let you know that Donna Cantrell, our staff support, she's here. She's in an undisclosed location, ready to meet all our technology needs. So thank you, Donna, for truly showing us what it means. So Monique, I'm going to turn things over to you for the welcome and the roll call.
All right, sounds good. So again, welcome to the meeting, and thank you all for being here. Donna has done a lot of work to get things put together, and we might still have some glitches along the way because that's just how technology is. So please bear with us. And if you're having difficulties, Donna, what's the best way for folks to communicate if they're having
Probably put it in the text box right now. I'm monitoring it. And,
Okay.
But one thing I need before we get started is to find out who the phone numbers are on the screen. Who is the 629-8288 number?
Donna, that's Susan Moon.
Okay. And then who is the 240-6329 number? Who was that? Who was the 240-6329 number? Who is the 363? And who is the 363-1485 number?
That's me, Joni Latimer.
Gotcha, Joni.
This is Barbara. Can you hear me now?
Yes.
Okay.
Okay. So in terms of the roll call, can I go through and say each name? Is that how we're going to do it?
Yes.
Okay.
And so here's what we're going to ask you all. Monique, we have to go ahead and note everyone that's in the meeting for the record. If you would go ahead and mute your phones right now. And then when Monique calls your name, unmute yourself and then mute yourself again.
You are muted.
Okay. So I know I am here. Mark Bender.
Hi. Are we also supposed to say who we are, where we're from, that kind of thing?
Sure, why not?
Okay. Mark Bender. I am a rehab psychologist, currently with the Department of Physical Medicine and Rehabilitation at VCU and Sheltering Arms Institute.
Thank you. Cara Mexner.
Hi, good afternoon. I'm Cara Meixner. I'm a professor of psychology at James Madison University.
And then we have Mike with an adorable co-meeting participant.
Yeah, Mike Puglia, certified athletic trainer with HCA Virginia Sports Medicine, and I'm in here with my co-meeting partner here, Jacob Puglia, who is 2 years old now, or 2 weeks old now. Look at him.
Oh my God. Congratulations.
Thanks, guys.
Ann McDonald.
Present. I'm the Executive Director of the Brain Injury Association of Virginia and say welcome to our new members today.
Yay. Jason Young.
Hey everyone, Jason Young, Executive Director of Community Brain Injury Services. I serve on the Alliance as the chair of the Virginia Alliance of Brain Injury Service Providers. Welcome.
All right, John, you're up. John Heath.
I am John Heath. I'm the volunteer family ombudsman for the TBI, federal TBI grant. And I currently live full-time in Colonial Beach, Virginia, where I help run a nonprofit for the local school kids.
Awesome. Okay, and now Cara Beatty.
Okay. Hi, I'm Cara Beatty, and I am a psychiatrist in Richmond. I specialize in neuropsychiatry, TBI, and I actually am a survivor of a traumatic brain injury. So welcome to all the new members. Thanks.
And I'm saying the names wrong of people I know the most, so that's always Classy. John Reynolds. I'm not sure if I see you. Is John Reynolds here? Yes.
Not according to what I see, no.
Okay.
Hey, John emailed me. He was trying to get in, so I'm not sure if he needs a re-email.
Thank you.
Yep.
Okay, so we will hold on him. Sandy Parker.
Hi, yes, I'm here. I'm calling in from Hampton, Virginia, and I am a mother of a TBI patient and caregiver, and he's currently up in Boston at Braintree Manor, and I'm here on his behalf.
Thank you. Welcome. Okay. Cynthia Jarmell.
Hi, I'm Cindy Jarmell. I'm licensed clinical social worker at the Salem VA Medical Center, where I'm the TBI coordinator.
Welcome. Okay, and then Nick Redisil.
Hello, Nick Redisil, survivor, VA.
Thank you. Where are we here? Carson Ward. Not seeing Carson on my screen. Okay.
Yeah, I don't have a record of him either.
Okay. Victoria Newman.
Hi, I'm Victoria Newman. I'm a TBI survivor. I'm new member, and I'm the founder of the Valley Disability Support Group in Front Royal, Virginia.
Thank you. Welcome. Jean Hoyt.
Hi, Jean Hoyt, Injury and Violence Prevention Coordinator, Virginia Department of Health.
Thank you. Gail Brunk.
Hi, it's Gail Brunk, Executive Director for the Center for Independent Living, Dale, in Harrisonburg, and current President of the Virginia Association of Centers for Independent Living.
Thank you. Okay, Chris Miller.
I'm here, thank you.
Okay. Deborah Johnson. Okay, and I don't see her on my screen. Erica Lawhorn.
Erica can't be here today.
Okay. And then Jeff Kretzer, are you here? Or Jenny Marowitz?
Yeah, Jenny, Dr. Kreutzer can't be here. I don't know. Jenny, are you here?
I'm here. Yeah, Jenny Marowitz, Virginia Commonwealth University, Physical Medicine and Rehab. I'm with the Traumatic Brain Injury Model System Grant.
Awesome. Okay. Kevin Kozoil. Is that right?
Yeah, it was very close. Hi, Kevin Kojoul. I'm Director of Independent Living here at the Department for Aging and Rehabilitative Services. I work closely with the Centers for Independent Living across the Commonwealth.
Thank you. Welcome. Joni Latimer.
Yep, I'm here. Joni Latimer, State Long-Term Care Ombudsman, and my office is also with Department for Aging and Rehab Services.
Awesome. Mark Murphy. Barbara Seymour. Hey. Barbara. I see you.
Barbara's here. Yeah, Barbara's here.
Okay. Maybe muting difficulties. I'm sorry, I made it. Maria Stransky, I think I skipped you. I'm sorry.
No problem. I'm Maria Stronsky with Mental Health Services with the Department of Corrections.
Okay. Elizabeth Horn.
Elizabeth, unmute yourself.
I see her.
Liz? I see her too.
I just had trouble.
Okay. All right, George Worthington.
Hi, I'm George Worthington. I'm the Dementia Services Coordinator with the Department for Aging and Rehabilitative Services.
Hey. Catherine Hayfield.
The commissioner's not able to join us today,
Okay.
but she's looking forward to
Monique?
seeing the recommendations.
Yes.
John Reynolds has come into the room, and I believe Deb Johnson is dialing in right now.
Okay. Johnson dialing in. Reynolds, where are you? I'll find you. I'll find you later. Okay. All right. So we said commissioner can't be here. Thank you. Marcia Dubois.
Marcia Dubois, Deputy Commissioner for the Division for Community Living for DARS. Good afternoon.
Good afternoon. Okay. And Carolyn Turner.
I'm not sure if Carolyn has audio today. She's been having some technical problems of her own. So,
hello everyone. It's Carolyn Turner,
hey,
with Director of Disability Programs with DARS. Good afternoon.
Good afternoon. Wanda Allen.
Monique, Wanda's watching on the live YouTube screen, and everybody else should be watching on the live YouTube screen too. So that's as far as we need to go. It's through number 30.
Sounds good. All righty. So thank you all and welcome. So let us go to our agenda. Bear with me, I'm on 2 different computers. I couldn't print stuff out, so trying to go back and forth with screens here. Okay, so now we will have, so Chris Miller is going to give us an overview of the electronic meeting requirements. Chris.
I'm guessing that by now, most of you, if not everyone, has been in enough Zoom meetings that other than all of us just remembering to unmute ourselves, that you kind of know the deal, but we want to just remind you about a few things. Because this is an electronic meeting and has to adhere to some certain rules, please do remember that this is being live streamed on YouTube, so you can go back and watch yourself at some point if you're so inclined. As we mentioned at the beginning, please keep yourself muted when not talking so that we just don't have too much background noise. Please don't use the chat to offer comments because that can't be seen by the public as a whole, and we want to adhere to the transparency goals of all of state government. Please do use chat if you need to communicate with Donna and let her know if you're having some kind of trouble or if you've been trying to speak and you're just not getting recognized. So Donna will be monitoring that to keep an eye out for that. Each time you do speak up to say something, we do ask that you identify yourself by name. And again, that's so that the folks who are watching on YouTube know who's speaking, and also so that we have it in the formal record. Just wanted to remind you of a few things. I'm going to pull up a little picture here. Well, I thought I was, but hold on one second. Wanted to just show you where the things are for, obviously I can't talk and click around at the same time. So anyway, I thought I had here available, but to remind you how to mute, if you go down to the bottom of your screen, you should see a little menu come up and you can just click on your mute and unmute. You can also stop and start your video if you should need to do that. If you click on the little thing that says participants, that will also give you the opportunity to raise your hand or not, or you can go over to the far right where it says reactions, and that will also let you raise a hand as well. But again, if you're having any trouble, please do go ahead and chat with Donna, and she will help you out. Does anyone have any questions right now about how we're moving forward or what we need to do for this meeting? All right, then I'm going to turn things back over to Monique.
Thank you so much. Mike, did we miss our chance to get a close-up of the babe?
No, here you go.
Okay. We have to introduce this new member first.
All right, so his eyes are open now, which he's been sleeping all morning, but this is Jacob Alden Puglia. He was born 2 Sundays ago, so on the 12th, and baby and mama are doing really well. Full head of hair on this guy.
Yeah.
I know, so this is gonna be, he's got more hair than his father, that's why I'm wearing a hat. And he's got a lot of opinions, so he's ready to get on with the meeting and get some voting on.
Awesome. Thanks for that. He's absolutely precious.
Thank you so much.
Okay. All right. So with that, I will go on and meet our new members or introduce our new members who can eat solid foods. So our first position, so I'm going to, and I think I said your name incorrectly. Cynthia, did I say your last name incorrectly the first time?
Jarmell.
Jarmell, thank you so much. Okay, so Miss Jarmell is a licensed clinical social worker, and she's currently employed by the Salem Veterans Affairs Medical Center. She resides in Southwest Virginia, an area of the state that is underrepresented on council. She works with veterans who've experienced a TBI and has considerable experience with aging and dementia. Ms. Jarmell was nominated by at-large member Nick Redisil, who is currently serving a 3-year term as a survivor representative. So welcome. We are very, very happy to have you.
Thank you.
Okay. And our next new member that I will introduce is Sandy Porter. And Miss Porter is the mother of a person living with a brain injury who is currently being treated and housed at Braintree, as she stated, which is an out-of-state neurobehavioral treatment center for individuals in Massachusetts. She lives in Eastern Virginia, in an area of the state with no other representation on council. She is a quality assurance coordinator in healthcare and is a medical transcriptionist. She has firsthand experience with the challenges of out-of-state placement for treatment/care that would be beneficial in the discussion around efforts to develop resources in Virginia to meet those needs. So we greatly need your input, and we are very happy to have you. So welcome.
Thank you. I'm glad to be here.
Okay. And Victoria Newman. So council requested that the commissioner.
Excuse me. This is Barbara.
Hi.
And I'm sorry, I'm having trouble with sound. But it's Parker, not Porter.
Did I say
Sandy
Parker? Sorry. Oh. I'm sorry. I did. I'm so sorry. And I know it's Parker. I apologize.
Okay. All right. Okay. And I just want to give a shout out for her. I nominated her, and I think she'll give us some good insight.
Thank you. I hope so.
Sorry, Ms. Porter, please forgive me. I'm sorry, Parker. Mrs. Parker, looking at being corrected on the sheet that I'm reading from, and you will learn this about me in the short time that I will still be doing this. I get very nervous at these meetings, so I kind of I have a little bit of an anxiety. So I very well know and was supposed to make the correction on this sheet, and I apologize. Okay, so Ms. Newman, so we requested that the Commissioner of DARS use one of her 2 available commissioners designee positions to appoint Ms. Newman, a person living with TBI, to a 3-year term on the Virginia Brain Injury Council. Now I'm not going to trust anything I'm reading, so you're going to watch me stumble over my words. Ms. Newman resides in Northwest Virginia, where she leads a brain injury support group and is passionate about improving outcomes for individuals with brain injury, particularly those living in rural communities. She's a business systems analyst and has experience working in information systems and marketing and web design. So thank you very much for being a part of our group.
Thank you. I'm glad to be here.
Happy to have you. Okay, let me switch back to my agenda. Okay, so at this point, we will move on to reviewing the proposed agenda. Has everyone had a chance to look over the agenda? And does anyone have any amendments they'd like to make to it, changes? I'm just giving a little extra time because I know that there can be some issues with unmuting and everything, so. But I'm not hearing any concerns with today's agenda. So with that, I'd like to move to approve the proposed agenda.
Second.
We have John. Can someone second John?
I can second that.
Thank you, Mike. Okay, so with that, our agenda is approved. So we can move on to reviewing the previous meeting minutes. So has everyone had a chance to review those? And are there any corrections that need to be made to the minutes from our last meeting? Okay, with that then I will propose an action to approve the minutes from our last meeting.
So moved.
Can anyone second, please?
Second that.
Who was that that motioned? Was that Mike?
That was Mike, and I don't know who's second.
Cara Beatty.
Thank you.
You're welcome.
So Monique, we will need to take a roll call vote on this.
Oh, they both do say roll call. I wasn't sure what that meant, actually. So everyone will have to say if they approve. Is that the idea?
Yes, if you would just go through the roster again of the board members only, or the
Gotcha.
council members only, and ask them to vote yes or no on the minutes.
Okay. Alrighty. All right, so we got Cara, right? That counts. And Mike, okay. So John Heath,
Yes.
John Reynolds. Oh, he's not here, right?
I'm here.
No, he is here now.
Yes.
Thank you. Sandy Parker.
Yes.
Members, okay. Cynthia Jarmell.
Yes.
And Nick Redisil.
Yes.
Okay. And then where are we? Kirsten's not here. Victoria Newman.
Yes.
Susan Moon. We'll come back. Jean Hoyt.
Yes.
Gail Brunk.
Yes.
Chris Miller.
Yes.
Where are we? Where are we? Sorry. Joni Latimer.
Yes.
And
Yes.
Oops. I think Jenny Marwitz is here, right?
Yes.
Okay. And then Kevin Kozel, I know you told me and I forget how to say the last name again.
It's quite all right. It's Kojal, and I vote yes.
Thank you. Okay. Maria Stransky.
Yes.
Barbara Seymour. Seymour, sorry. I'm not sure if I heard.
Yes.
Okay, thank you. Elizabeth Horn.
Yes.
George Worthington.
Yes.
Marcia Dubois.
I'm not a member.
Oh, sorry. Am I done? Am I done?
Monique, you never called my name. This is Ann McDonald. I think you have missed some other names. I don't think Jason's name was ever called.
I'm sorry. I'm looking at this sheet and I'm trying to go line by line. I'm not sure. I know I never called your name. I'm not sure where on the list.
Monique, I've got the list running, so I know who hasn't responded yet. Can I just go ahead and call a few more?
Yes, please.
So Ann McDonald,
Yes.
Jason Young,
Yes.
did we get Susan Moon?
No.
Okay. And I apologize, did we get Deborah Johnson?
No, and yes.
Okay. And did we get Jenny? Jenny, I apologize. Did we get Jenny?
Jenny Marwitz is yes.
Okay. Is there anyone that we missed?
Is there anything else I have to do with this list? Because it seems like I've messed mine up. So I either need to open a new one, but if there's nothing else I need to do with that list, then I'm okay.
We'll have to take
use the
one
other
more
roll call.
vote.
I'll send you a new one.
I'll just reopen it. I must have deleted lines or hit something, but I'm not seeing.
And Monique, I have a list that has spots for the voting too. I'm also glad to do the roll call if that helps out.
Okay, that might be helpful. Yeah, I'm not sure what I did here, but Ann and Jason aren't here anymore. Okay. All right. Okay, so we are done. So now I know that Donna, you do have some public comments that you received in writing. Would you like to go ahead and review those now?
I will once I unmute myself. Yes.
Thank you.
Public comment. We had one public comment that came in. We received one public comment from Rachel Evans, Executive Director of No Limits Eastern Shore Brain Injury Services, the state contracted brain injury service provider for the Eastern Shore region. She says, thank you to all committee and council members for all of your hard work on behalf of Virginians who have survived brain injury. We are concerned on the Eastern Shore about survivors of brain injury in Virginia who are confined to congregate care due to lack of independent living options. In our small region, we currently serve 13 survivors of brain injury who live in congregate care settings, 12 of whom are in nursing homes. The majority of these individuals are in their 40s and 50s, although some are older and one is not quite 30. Like other survivors of brain injury in other regions of Virginia, they are not considered to be near the end of life, but have significant care needs and have not been able to access support sufficient to maintain them outside of congregate care. Unless and until they are deinstitutionalized and integrated into the community, efforts should be made to ensure that these individuals have reliable and accessible means to communicate with the outside world. We work diligently with our area long-term care facilities, and we work closely with the Area Agency on Aging long-term care ombudsman for our area, but access to the people we serve in long-term care during the pandemic is uneven at best and non-existent at worst. We serve 2 men in their 40s in one facility who sustained and survived brain injuries decades ago, young enough to make them eligible for aids funded through OBRA, but now administered through the Community Service Board. The OBRA aides accompanied them to No Limits Day support programs and provided cognitive support at the nursing home. They have not had access to this support since March. We see them in our virtual No Limit Zoom meetings sometimes if the right staff is on duty at their nursing homes or brings them the Kindle devices we set up and sent them with joining instructions. They are always lying in bed, and they are always so happy to connect with their No Limits network. We are working for and with the community we serve to resolve individual issues, but if the Virginia Brain Injury Council or any of its members has the opportunity to advocate for or act on behalf of survivors of brain injury residing in long-term care settings, please do so. Thank you. And that's the end of it.
Thank you. Oh, I don't know what I just did.
This is Barbara. Can I say something?
Yes, go ahead.
Hello. Okay. I am currently sitting on a Virginia Department of Health work group that's regarding a mandate from the General Assembly for recruitment, I guess, or healthcare workers. And
Barbara, we've lost your audio.
I know mine also got a little hinky just now. It wasn't supporting video for a minute. So maybe something's going on. Can
you hear me now?
Yes, we can.
Okay. Anyway, this is a significant issue nationwide with the nursing facilities. We had several representatives on that work group talk about the condition of their loved ones and really trying to advocate to get something done about the condition of these folks that the families can't even see. Some of them aren't even allowing the families to go to the window like you've seen in the news sometimes. So anything I think our council can do to move this along a little bit from that piece. The main piece of our work group is looking at how these facilities are staffed and focusing on what we can do to entice or enhance the attractiveness of positions in nursing facilities. The CNA that is going on. It is a real struggle out there.
This is Gail. Can I make a comment as well?
Please.
Sure.
I hear what Barbara's saying. I would like to also add to that. I think we need to be advocating for community-based services. We've seen what's happening in our congregate settings of nursing homes, and I believe we have to have a stronger push for community-based services that truly meet the need.
Completely agree with Gail's comments. This is Ann.
So I want to thank you all for this. I want to say the purpose of the public comment is not necessarily that the council has to respond, but what I think is really important then, and this is a nice segue into our next step, and that is for you to keep those thoughts as we move forward to talk about the priorities. This certainly is a big issue that we could spend a whole lot of time on. But let's go ahead and move into the larger context of the priorities committee and keep these thoughts in your mind.
Somebody needs to unmute, or somebody needs to mute themselves.
Yeah. Barbara, can you mute?
Chris, are you using your phone and have your computer sound on?
No, only the computer.
Okay.
Okay. So, Kristen, would you like to go ahead and review the background materials for us, please?
Glad to. I'm going to spend just a little bit of time on this, and then I'm going to turn things over to Ann McDonald, who's going to talk to you about the actual recommendations. I want to first say a big thank you and commend to the council the folks that worked on developing these priorities. Ann McDonald is the chair of the Priorities Committee. Monique was a member. Cara Beatty was a member. I got to sit in and be a part of that, and Donna provided, as always, her excellent staff support to this group. And they started working on this process soon after the council meeting in January, and spent a lot of time in discussion. You all then responded with your thoughts from your individual perspectives, whether it's as an individual with a brain injury, a professional that works is somehow related to the field, a family member or a caregiver. And we took that feedback then and put that out into a community survey. We know from the feedback that we got that the community survey certainly had some quirks that did not necessarily work well, especially for consumers. But there was valuable insight in that feedback that came back from the survey. And then there was also input from other community organizations and data that we could draw from a variety of different sources. So over that 5-month period, using all those different ways of soliciting input, the committee came to the recommendations that Ann's about to present to you. You should have a summary of that information that you've received from us that includes some of the data sources and some of the information. One of the things as we go forward from here, before I hand things over to Ann, that I want to just remind you is you have a set of recommendations from the Priorities Committee. You can endorse all of them. You can endorse some of them. You can ask questions to help get a better sense of this. You may choose to introduce something else, and then we will come out with a list of priorities at the end of this meeting that the Priorities Committee will then submit in a letter through Monique as the chair to the commissioner. So Ann's going to present more on the actual priorities, and then I will come back and we'll start soliciting your input as well. So thank you, Ann.
Thanks, Chris. You know, it was I've been on the Priorities Committee for a couple of years, and the tenor of the committee always changes. This was a really active and engaged committee, and I was really happy to work with them. I was very happy that we had some folks that haven't served on the Priorities Committee before, so they were really looking at this with a lot of new eyes. So I'm going to share my screen and talk through. Donna, can you allow me to do that, or Chris, whoever is the...
Okay, hold on. I can do that in a second.
Yeah, Donna, you'll need to make her co-host.
Well, I'll sort of continue to keep going as Donna is trying to get me to the point where I can share my screen here. So, you know, we looked at we had a number of conversations about how we were going to do this. And one of the things that we decided to try to do was to send the survey out to the broader community, to provide the council members with some ideas about what was happening outside of the little room that we meet in. In the past, the Priorities Committee is pretty much focused on the work of the council and the things that we've been hearing over the last year or so. But we took a very different approach this time, and I was really delighted to be part of it. We looked at a variety of services that individuals were concerned about or wanted to know more about or thought that you know, we should investigate as priorities. So we came up with a couple of different priorities. You know, we have needs as regards future planning, and where our resources need to go in terms of some service areas. And so you'll see those here in recommendation number 1. We talked a little bit about disparities across the Commonwealth that result in waiting lists for services, as well as the absence of services in a number of areas. And we also talked about some of the things we've been trying to make happen with the Department of Behavioral Health and Developmental Services. So we'll talk about these in just a little bit more detail once I give you some background information. So we had 133 responses to the survey that provided us with the information that you see in the following graphs. When we asked folks, you know, what was the most important of these general service categories in terms of where we needed to put some of our efforts, the number 1 was community-based services. You can see that it received the highest score, and we worked ourselves down. I thought technology being the last one was really interesting, given that we're all doing so much work in technology these days, but that's not necessarily where folks are feeling like they need the most help. When we specifically drilled down into each of those categories and said, so what of community-based supports is the most important to you? What we found were there were some that were endorsed by more than half of the respondents, and those were future planning, transportation, and supported living. So, you know, the future, as I was saying in a meeting this morning, I think future planning and yes, ma'am.
And unfortunately, I need to put this on hold. We've had a technical glitch, and so the captioner is typing in the chat box, and it's no longer viewable on YouTube, so we have to stop for just a moment.
Okay.
So Betsy?
Yes, yeah,
What's to happen?
I mean, Debbie's on, the captioner's on, she should hear us and.
She adjusted,
Okay.
it's now working
Okay.
properly.
Okay, thank you. Sorry about that.
I'm sorry about that, Ann, go ahead.
That's okay. It was helpful to go back and look at the chat and see where I left off. So what I was saying in a meeting this morning, that I do think that this future planning and supported living are probably really closely related. People are really worried about where folks are going to live in the future and how they're going to be cared for once aging parents and other people who are supporting individuals with brain injuries are no longer able to do that. The other categories you can see here, these were the most highly rated item in each of the categories. So in community-based supports, the number 1 rated service was case management. In crisis management, the number 1 rated service was community-based intensive services. So what this does is it tells you general categories for us to turn our attention to, and then if we need to drill down with some specificity, what specific service in each of those categories was really highly correlated to what folks felt like they needed. In terms of addressing disparities across the Commonwealth that result in rating lists and some of the services in some areas, this is a map that the Brain Injury Association of Virginia does every year. And what you can see are the areas that are served by programs that are already funded through state dollars and areas of the state that don't have any funding for brain injury services specifically going to those localities. So you see here in this very bright blue, this is a service area for brain injury services in Northern Virginia. And the number of people who are estimated to be disabled by TBI and stroke in that service area is 106,000. And last year, brain injury services indicated that they were serving way less than that. If you only looked at direct services, it's about 1,000 people. So they're serving less than 1% of the folks that might be eligible for services. And those are individuals who are disabled as a result of brain injury or stroke. This is an area here in this coral, that's Bridgeline, which covers the Shenandoah Valley and along the 81 corridor, or sorry, they're the orange, and the coral is community connections to brain injury connections of the Shenandoah Valley. Sorry about that, they changed their name and I'm still trying to get used to it. This yellow out here is Brain Injury Services of Southwest Virginia. This light green is Community Brain Injury Services, which covers Richmond and the Newport News area. The darker green is served by Eggleston, specifically the Beacon House conducts a clubhouse and case management services. Eggleston is a very large provider and Beacon House is a small little subset within that agency. And here in the pink, that's No Limits Eastern Shore. So all of the areas that are in white have no community-based, state-funded brain injury service provider covering those areas. So they don't have access to clubhouses, they don't have access to case management. Brain Injury Association of Virginia obviously serves everybody across the state, but the services that we provide are not those direct hands-on services that sometimes make a difference to folks. I can tell you that based on what we know about funding, we do have some issues related to, you know, the number of people that are in a service area versus the number of dollars that they get. For example, the area in Virginia Beach is one of the most densely populated areas of the state, but one of the programs that receives the least amount of money. So when we talk about the number of folks that they're able to serve in their program area, it's fewer than it probably should be, given the density of the population. So we do absolutely have a need to address these sorts of issues as well. And in the last one, in 2015, the Brain Injury Association of Virginia, the Virginia Alliance of Brain Injury Service Providers, snuck in some budget language that basically said to the Department of Behavioral Health, you're going to have to start telling us the number of people with brain injuries you're serving. And so we did get a report from the Department of Behavioral Health that year, and it was able to tell us the number of folks that were being served with brain injuries in the state mental hospitals. But we had specifically asked for that number to be inclusive of folks that the community services boards were serving with folks with brain injuries. And what we were told is because the community services boards don't ask whether or not somebody has a brain injury, they can't report those numbers to us. And we all know that the community services boards are working with folks with brain injuries. So, you know, we've had a couple of different things that have sort of, we've tried to get done in terms of data from the Department of Behavioral Health and working with them to better meet the needs of some of the folks that we are all seeing. And because of staffing changes at behavioral health and, you know, a few other things, that sort of has dropped off the radar, and Chris is ready to pick it back up. So I'm really happy about that. I do think that we have a plan for trying to get some of this collaboration going with the Department of Behavioral Health relative to some data sharing, but there's a good bit of work that needs to be done. And unstated in this section is that for us to get the number of people with brain injuries who are at the CSBs have got to start screening. They are not going to know how many folks with brain injuries they're serving until they start asking the question. So while that's not necessarily stated in here, that will be part of the conversation going forward. So we would like the recommendations of the council that go to the commissioner to talk about what we learned from the community survey, that there needs to be some attention paid by the agency to this issue of housing, whether that is developing the capacity of programs or becoming engaged in more housing conversations and helping us figure that out. We don't know, but we got to figure out something related to housing. We need to figure out how to fund some of the supports that folks are telling us that they need. We probably should be engaging more in some of the conversations around transportation. So we'll highlight these areas in the priorities letter, that we should consider these 5 areas as priorities: community-based supports, crisis management, housing and residential services, education and outreach, and caregiver supports. We can drill down specifically and talk about the 3 that were endorsed by more than half of recipients that we would like to see DARS develop some sort of response to. We can make a statement that we feel DARS should assist us or DARS should work with us to address some of the disparities across the Commonwealth. And by us, I mean the Brain Injury Council and the state-funded brain injury programs. So how we go about addressing the disparities that we know exist is something that we'd like to have additional conversations about. And then this work with the Department of Behavioral Health to comply with the requirements of the budget bill and to see if we can't get a little bit more information about how we can work more closely to best meet the needs of individuals with brain injuries who are also experiencing some behavioral health comorbidities. That's a lot of information to take in. I'm really glad you got this information ahead of time, and I think I'm going to stop there and open it up to questions or additional comments.
Okay, so folks, so as Ian mentioned, there has been a whole lot of information shared, but this is the point where we want to hear from you. Any questions or thoughts that have come up for you? If you would unmute yourself and offer your thoughts on this. Would anyone like to start?
Hey everyone, Jason Young with the Virginia Alliance of Brain Injury Service Providers. We actually we have our meeting just prior to this, and one of our topics was to review the priorities letter that the council, that y'all are reviewing right now. And I just wanted to add that we were, and this is kind of unusual for us sometimes, but we were very supportive of all the priorities on there. We had a lot of discussion among our provider network, particularly around the housing issue, and that being such a critical issue and such an unmet need for survivors around the state. And that is something that is an alliance that, and BIV last year, we put in some advocacy work around that housing issue, and that's something that we see as a huge need as well. And the other thing that we were excited about was, picking up the torch again with the Department of Behavioral Health. And particularly the fact that DARS, as the lead state agency for brain injury, is going to kind of be taking the mantle, if you will, and engaging with the Department of Behavioral Health. The advocacy providers and BIV advocacy groups have been engaging with the Department of Behavioral Health since 2015 about this, and it kind of goes and frets and starts, and then we don't hear anything from them. And I think we all know that state agencies have a different communication pattern and response pattern to other state agencies than they do with outside advocacy groups. So we thought that having DARS being the one that kind of is taking up the mantle and starting the communication with them was definitely a step in the right direction with that. So that was our comments and feedback, very supportive in general of all these priorities.
Thank you, Jason, appreciate that. I'm going to put some people on the spot. Kevin and Gail, I'm wondering if there's any input from the SILS, the independent living part of DARS, on these priorities.
Well, this is Gail. Seeing as I think I just received that email, I have not had a chance to disseminate it to gather any feedback. So just from my perspective as a center director, as I stated earlier, community-based services is critical. I think one has to be careful in approaching the CSBs to do more work. I've worked for one. I've got a daughter who works for one, and continuing to put more on them, there's got to be a little bit more support for asking them to do yet another assessment. I don't think that's something that you can be asking case managers to do when you look at what has been on the DD side in particular, put on top of them of what they now need to do their job. So I do think community-based services is the critical need. I think there may someday be an opportunity, this is just me talking off the top of my head, for some type of partnership in figuring out how SILS and brain injury might be able to continue to work more collaboratively. I think some have very close relationships and others have good relationships, but maybe not as close as what we could figure out how to make them be.
Thank you, Gail.
Thanks. This is Kevin Kojal. I wanted to echo Gail's comments about the need for increased community services, and I also wanted to thank the Priorities Committee for just really great work, and it clearly thoughtfully done, and the data that were considered, it's very helpful. I did want to make a comment about the third recommendation and sort of the way it's framed. I really, for my part, I agree with the premise and sort of piggybacking off the idea for increasing community-based services, but it seems to me that the purpose of the third recommendation is to support the capacity of CSBs, substance abuse providers, mental health providers, maybe other community-based providers to support folks who have brain injury that co-occurs with substance abuse, mental health, maybe other kinds of needs. And so another way to think about this is to think about framing it as a recommendation to support these kinds of collaborations, maybe bringing people with expertise in brain injury and substance abuse, mental health, other needs kind of together as providers. So I think there was some reference to innovative practices that could be fleshed out, brought together so that there's increased collaboration. And my concern, I guess, is the way that it's sort of framed. I think the purpose is there for me, but the way that it's kind of, the language comes out, I think that maybe a broader purpose could encompass some interagency collaborations, but that's my thought on that. But thanks again to the committee for the great work.
Thanks for your input, Kevin. Does anyone have anything that they would like to say or respond?
Chris, this is John Heath.
Hi, John. Thank you.
First of all, I wholeheartedly agree that they did great work on this document, and I'm very pleased to see the emphasis in there on transportation, as everybody, as I can see Ann laughing, as everybody knows, I'm a big proponent for more help in the transportation area, and I'm glad to see that the respondents to the survey, bore out my concern, and I think it goes along with housing as well, because obviously if you can solve some people's housing issues, it helps solve their transportation issues in a lot of cases as well. So I'm very glad to see that on there, and again, I think they did a great job, and I appreciate all their hard work.
You were the first person I thought of, John, when I saw that data come back.
Thank you, John.
Cool.
Other feedback, other responses?
Hi, this is Victoria Newman. I wanted to comment about the need for additional data from CSBs. In our area in particular, there seems to be more of an emphasis on the substance and mental health, but we seem to have a shortage in the number of neuropsychiatrists who actually, know and work directly with the issues concerning a person with a traumatic brain injury. So my question to the committee about this particular priority is the focus mainly about the initial crisis or the initial injury itself, and it posing other constraints on the actual survivor themselves if they had an existing history of mental illness, or is this more specific to services for TBI survivors that would include cognitive behavioral therapy, these kinds of things for adjusting to living with a brain injury, but also resilience in that area. And the second thing that I wanted to comment on was the availability of funding in Rappahannock County, which doesn't have any coverage right now. Rappahannock County is sandwiched between Warren County, Madison County, Fauquier County, Page, and it's on the further end of the rural spectrum. I could easily see people from Rappahannock County having their area extended to maybe go to Fauquier or Warren or maybe Page. So I didn't know if it would be a possibility to have Rappahannock County serviced by extending the coverage of the counties that surround them as maybe an option. And I did want to say that I was very excited to hear about the priorities because housing, transportation, of course, and case management is something that is still ongoing need here. And I thank you.
Thank you, Victoria. And I want to start by clarifying one thing, because I think your first question brings up an important point. And then if anyone on the committee feels that we want to add anything else related to that. So community services boards are by regulation the state service providers for individuals with behavioral health, substance use disorder, and intellectual developmental disabilities. So those are their priority populations. And this language is about folks who have one of those diagnoses co-occurring and making sure that if they have that diagnosis, in addition to having a brain injury, if they have both, that they get the same access to services. So it's not about adding people just with brain injury, but it's so that if you have a brain injury and you also have a mental illness and you present for substance use disorder services or mental health crisis services, that you're not told that you have a brain injury, so you need to go just to the brain injury providers, but it's to acknowledge for those folks with multiple disabilities that they get access to those important services. Would anyone else on the priorities committee like to add anything to that?
This is Ann, and I'll jump in. I think that the other thing that's probably important to remember is this is specifically related to budget bill language. So this is something that's has been endorsed by the General Assembly through the budget process. So it doesn't necessarily have the weight of law, but it sort of does. So in order to expand what we see in this priority to any other group, as was mentioned by Victoria, that would require legislation or budget language. So right now we are sort of limited with this approach to just the language that already exists in budget language. And to sort of extend that a little bit, Victoria, to your comment about Rappahannock receiving funding or Rappahannock being wrapped into one of the areas, we would need additional funding. You know, brain injury services and brain injury connections of the Shenandoah Valley have determined their service areas based on the funds that are available to them. So we would love to go into Rappahannock. We would love to go into the Middle Peninsula and Northern Neck, and we would love to see Southern Virginia. But there's going to have to be more money appropriated for community-based brain injury services to make that happen.
So I want to add on just a few other things, I guess from a more clinical perspective. So thank you so much for your questions, first of all, very thought-provoking. The first thing is, you know, of course, and I think a lot of us know this, that with traumatic brain injury, a lot of times depression and anxiety, that's mostly what we see. And it actually shoots up exponentially in somebody that endures a brain injury versus not. What I see, just being one of the few neuropsychiatrists that's out there, is that people will get turned away because they'll say, no, now you have a TBI, even if you had a pre-existing condition of some sort of mental health issue. This is TBI, we don't deal with this. At the same time, I see colleagues that work with TBI and they see mental health on there and they say, no, I'm not gonna touch that. So, you know, it's really trying to blend those two because it is the same organ, just, you know, two different sides of the coin, I guess. And then the second thing I was gonna point out, and I know I have done this with some of my patients, in regards to getting patients to a CSB that maybe is better funded, maybe had better access to different things, you actually can do that. You can do like a one pass and get somebody into a different county. And if you have somebody that kind of advocates or says they need this, I know I have sent people to Chesterfield to their CSB that have they have a DBT group, and I try to get people into that. And if you talk with case management, they will be willing to do that. I think if you have a little bit of a push from a provider as well, it can be.
Sometimes Henrico won't take anybody that has a brain injury on their list.
You know what?
We appreciate the perspective. I think that.
Thanks. And I'll talk to you about that later, because I know somebody. Okay. I'll twist some arms for you. Okay.
Thank you, Cara, for weighing in. I appreciate that, especially with your perspective. Other thoughts, other input?
I just wanted to go back at Kevin and Gail. You guys, excellent perspective on that and kind of our relationship with the CSBs, and to kind of reiterate, like, we've been asking for this information far prior to 2015. And then when Department of Behavioral Health and CSBs just didn't provide it, or every once in a while they provide a bit of information to us. So then we saw fit to go and get it ensconced, as Ann said, in the budget language. And so now it's a mandate that they have to give us this information, and yet they don't. So, you know, I get that there is a lot on the CSB's plates with the waiver redesign. They've had a lot thrust on them. Also with the waiver redesign, though, is now they are serving more people with brain injuries because more people with brain injuries are getting on the waiver. But I know when I go out and talk with CSBs, they're serving people with brain injury and they don't know squat about brain injury. So it is unfortunate. It's frustrating. I just wanted to make that point that this is a mandate for them, and I don't think we should feel shy about asking them to fulfill their legally mandated responsibilities to report to us.
Hey, Jason, I'm not saying feel shy. We can take a different sidebar conversation, you and I. I'm just saying, unfortunately, the people who get held accountable to produce these things, I don't think are always the right people. But I've got a whole long conversation we can have about how we've gone astray on what we should be doing. But that's my only point, was let's be as direct as we can with who should be gathering that information.
Understood, Gail.
I have a couple of comments.
Elizabeth?
That's Elizabeth with the Disability Law Center.
Elizabeth, I can't hear you very well. You're muted right now, but also could you get closer to your microphone? So Elizabeth, you are muted right now. There you go. And could you get close to your microphone?
No.
There you go. That helped.
Hang on.
Sorry, I had the wrong mute in. Is that better?
Much, thank you.
Okay, I'm so sorry. Couple thoughts. The budget bill that the priorities letter as stated now is referencing is different from another budget bill that came out in 2015 directing DVHDS to allow individuals with acquired brain injury to access services for substance use disorders, community crisis intervention services, and drop-off centers. In conversations with Ann, I understand that we really can't seem to get a grip on the status of that and what, if anything, has happened in the last 5 years as far as that budget bill. So the legislature has in fact come forth and directed them to provide some of the very services we're all talking about, but to our knowledge, it hasn't happened. So it would seem that if DARS, initiates communication with DBHDS around this, that they could be asking about the status of that and encouraging them to move forward with that. And maybe they are, and maybe we just don't know about it. And in combination with that, I think we could all agree if they're going to be providing these type of services, there does need to be screening at intake. And I know that that may sound like an added responsibility, but we also know that there are many, many screening tools that have been developed that, we could help pilot which ones are most effective, most efficient. Even the one that UVA recently piloted with the 2 CSBs, the 3 SILs, I think, several AAAs. And, it was in fact, they discovered that out of 300 and some odd participants, 75 had brain injury, which is about 23%. I know UVA does a 2-tiered screening. There's some very basic questions, and if those are answered in the affirmative, then they know to forward them for a greater workup. So there's a number of ways of approaching the screening, but anyway, those are 2 of my thoughts about what we could do moving forward.
Thanks, Elizabeth. Appreciate that.
Mm-hmm.
We do have several survivors on council, and I'm wondering anyone who's living with experience wants to weigh in at all with your thoughts about what are proposed or what should be priorities that go in the letter to the commissioner.
This is Victoria Newman again.
Victoria, could you hold on one sec while
Sure.
while Nick Redisil goes ahead?
All right, no problem.
He was just getting ready to talk.
Nick Redisil. Yeah, rural areas is cities, all right. Rural areas is a lot of drive, a lot of is country is which yeah, cities is all right, is a little bit is also is drive 3 hours is Galax, whatever, is a lot of limited is thank you.
Thank you, Nick. We appreciate that. It's beautiful down where you live, but it takes a long time to get to services. Appreciate that. Victoria.
Okay, well, I just wanted to comment that sometimes whatever the mandates are, and I appreciate the additional clarification, but as a survivor looking for services, we are often turned away. That's what happened to me with the Community Services Board in my area. Because I had a traumatic brain injury, I was told I needed to go see someone who specifically, handled that type of treatment. So we kind of go around and around in circles and just find ourselves in a position where, I have a mild traumatic brain injury. So what that means is that, oh, you seem like you're doing pretty good for yourself, but our focus is mainly people that have a severe brain injury or folks that, are going to a facility and they've been diagnosed there and then they continue with their care. But people coming from, other areas or, states, or different counties that maybe received treatment partially somewhere else, and it may not have been adequate, and they go to, you know, a different system, depending on how the system works or doesn't work, will really determine the level of care that occurs. I mean, UVA has a wonderful brain injury department. I went to UVA starting in their neurology department, but never once was I ever referred in 6 years to work together with people who were mainly focused on brain injury. You know, it was always, well, you weren't this level on the Glasgow scale. You're not new to brain injury. So, you know, it's a horrible thing, but, you know, basically I'm just kind of going through the motions on just really getting the attention on the, you know, myriad of conditions that kind of go along with it. So the collaborative care part of it is, you know, sometimes a bit of a challenge. So my challenge to the committee and the commissioner is just trying to ensure that brain injury isn't necessarily a carve out per se, if that makes sense. But it's actually something that's a little bit more integrated, and, you know, it doesn't seem as complicated when people are trying to get, you know, help, that there can be some facilitation for that process from a survivor's perspective, because many times, you know, you don't know what you know. We know there's resources out there, but as part of the initiatives, just kind of understanding how challenging it can be to access information and, you know, get to case managers, but some additional assistance from providers is very necessary to help with that.
Thank you. Thank you. So we have a fair number of people here that work for other parts of state government. I'm wondering if you have any input or thoughts as we look at these recommendations.
Oh, Chris Miller?
Yes.
Chris, can you hear me?
It's a little bit faint, but.
Yeah, I'm having some audio issues. This is Susan Moon. I don't know if people can hear me well enough, but I am the representative from the Department of Behavioral Health and Developmental Services to the council. And I first wanted to thank the committee also for this wonderful work that they have done. I have participated on the priorities committee myself in the past, and so I know a little bit about how that works. And I think they did a phenomenal job this year. I wanted to say, when I read the documents for the meeting, and particularly their recommendations, of course, my attention was drawn to the Department of Behavioral Health recommendations. And I was not active in this role in 2015. And so I am not familiar with the history, but I hope to be able to share something of substance today. I can't, but what I would like to say is that in reading that, I have done more research and have already pushed the question/concern of the priorities committee to senior leadership. So there is an active process to look back and see where that was, where it was left off, what may or may not be occurring that has or has not been reported. And so I hope to become better educated and able to speak more to this as we go forward in the process. So I just wanted the group to know, and particularly the priorities committee, that their work is already making a positive impact in bringing that to the forefront and looking at what was done, what needs to be done, and where that can go. So I just wanted to share that that bit of information and that support.
Thank you, Susan. for being such a great advocate. That is just tremendous to hear. Appreciate that. Would anyone else like to offer something?
Hi, this is Jean Hoyt with the Virginia Department of Health. I also want to thank the committee for their work on this, and I've obviously sent the recommendations up the chain of command, through my chain of command, I should say, at the Department of Health, and I know that they're going to be happy to support the recommendations.
Well, thank you. Thank you also. And I would hope that Susan and Jean, both of you, as you've been sending information up, will also make clear that this is a two-way conversation. That, you know, and it's a kind of a, how can we help? How can we make this work for everyone? So thank you, Jean. We'll be interested to be here from both you and Susan. Any feedback?
Yes, looking forward to it.
I want to make sure that everyone that wants to weigh in or has something that they want to add gets the opportunity to do so. Is there anyone else who would like to offer up some thoughts about the recommendations? So in the absence of that, to me, the question becomes then, based on the discussion that you've just heard, is there anything that anyone might like to recommend that be tweaked or changed in the recommendations that were put out before the committee from the priorities committee? And I'm going to share those recommendations on the screen again so that you can take a look at them. So what we're looking for is this what you would like to go forward, or are there any recommendations for changes or revisions to them? Does anyone have any input?
Hi, this is Sandy talking. I don't know if you can see me. I turned on
Sure
my
can.
video. I was interested when I saw something, and I guess it wasn't on this particular document, but regarding to an in-state neuro rehab facility, so that we can get some of our approximately a dozen Virginians that are shipped off to Massachusetts with, you know, and they all have severe brain injury, so they're not able to live in the community or even in homes because of the level of need that they have. And like for my son in particular, he needs 95% assistance on his ADLs. And so for the last 10 years, he's been off to Boston, which makes it really difficult on me and our family. And especially in light of this COVID situation, we can't even go visit if we wanted to. And there's very limited staff there because, you know, again, limitations because of the pandemic. And so we're not even really able to FaceTime visit or with our family members. And I am in touch with several other families that have patients up there, and we all struggle with the same issues that we can't even see our family members. They were taken from us with this accident and then shipped off to Boston, where they lost all their abilities and they can't see any of their families and they're not in their home state. And so that's something that's been, you know, that I'm heavily going to advocate for, to try and get my son back home, even if he's in 3-4 hours away from me, as long as he's within the borders of Virginia. And all the money that Virginia is paying to Massachusetts when we could have it here in our home state. So I don't see that on this list. I don't know if it's anywhere else on any other agenda, but that's something I would hugely be interested to know was something that was on the plate.
Sandy, it has been in previous years. Are you saying you would like to see it included in this year's priorities letter?
Absolutely.
Chris, I just noticed something in B. We have crisis management and futures planning. And crisis management, if you go back and you look actually at the document, crisis management was we've conflated too. We've got emergency planning. That's where future planning was.
Okay.
Crisis management was community-based intensive services. And Sandy, I went back and looked at those things because I was pretty sure that we had mentioned neurobehavioral in one of those. I don't see it, but I think you bring up some excellent points. I've heard some of the same things of the difficulty that COVID has created for everybody that's out of state, and institutionalization is difficult under the best of circumstances.
Hey, this is Maria. I just had a thought I wanted to throw out there.
Yes.
Given all the social injustices and unrest that we've seen, I don't know if we want to say anything like in number 2, just talking about disparities, but also inequity and whatnot, and it's not just geographically, if like as Ann had mentioned, the organization that serves the northern part of the state, if they're only able to right now provide services for 1%, how is that distributed? So just to throw that in there to acknowledge that. Just a thought.
Maria, I want to make sure that I understand. What might be your recommendation for that, for number 2, to address what you're thinking?
I would have to give that a little more thought, wordsmith it in my head a little bit.
Gotcha.
Maria, it sounds to me like what you're talking about is when we draft the letter and we get to section 2, we start talking about disparities, we can bring in some of what social justice initiatives are telling us about disparities in terms of who's being served and where they're being served. Just a general statement. Is that what you were trying to say?
Yes, thank you, Ann. Yeah, no big change to the spirit, but just kind of further elaborating. It's more than just, hey, this particular geographic area doesn't have services, but also within the areas that have services, who's receiving those services? That kind of thing.
Yeah, that's an easy thing to add. And I think that there's so much that we could talk about the social inequity of individuals with brain injuries, and the service inequity. I mean, yes. Seriously, we should have people here in Virginia and we should have a waiver and stop putting people in nursing homes. That's the advocate talking.
We know you can't help it, Ann.
This is Victoria Newman.
Yes, Victoria.
Would it be appropriate for number 2 to mention funding for brain injury services so that they could possibly extend services to areas that need more coverage?
Sorry, I was talking and hadn't unmuted myself. Yes, Victoria, that's going to be part of number 2. When we sort of flesh these things out into a written document for the commissioner, we'll talk about the need for funding. I think there's 23 counties and cities in Virginia that don't have access to a brain injury service provider. And in those areas where access is available, there can be up to a 2 to 3 year waiting list. Our waiting list currently, as of today, is somewhere in the neighborhood of 65 to 70 folks waiting for services from one of the established providers. So that doesn't even count everybody that's not even on the waiting list yet. So we'll have a general statement about a need for increased funding for community-based services so we can expand into unserved areas and meet the needs of the individuals in the areas we serve.
That's great. Thank you.
This is Kevin Kojal. I just wanted to ask a procedural question, if I could. So presumably these priorities would be put into a letter. Is the council going to get to see the actual language of the letter before it's submitted, or how does that work?
That's a great question, Kevin. And there are 2 possibilities here. One is that you vote you vote to allow the priorities committee to develop the letter based on the approved priorities that you all decide as a group, and the priorities committee then just goes ahead and drafts the letter. The other is that you request that a letter be written and that it come back to council for review and approval.
Okay, thank you.
Yeah. So before we go to process the question that Kevin just asked, one of the things that I think that I'm hearing is that overall there is support for the recommendations that the priorities committee put forth, with the clarification in number 1 that futures planning comes under a different category, and that crisis management, and tell me if I'm kind of garbling this, that the addition of the need for neurobehavioral supports, and that in number 2, it will, in the addressing the disparities, that we will add the language about the social inequities among, I can't read my own handwriting right now, but that beautiful sentence that Anne said, that we would add that. Is that the feeling of the group? Is there anyone that feels that no, that's not accurate, or that they would also like to see something else?
So this is Joni Latimer.
Go ahead, Joni.
Yeah. So no, I'm not disagreeing at all. And number 1, I just want to also commend the work of the committee. I just think they've done an outstanding job. I've been a little reticent because I really I don't feel like I'm the resident expert in any sense on this subject area, but very interested in the needs, the advocacy around it, because we certainly see these needs in our world of largely working in long-term care facilities themselves. So I totally get the emphasis on community-based services and couldn't agree more. And I just wanted to take a moment to underscore, I think it was Sandy's comment. I myself kind of missed that mention of an in-state capacity to help some of the folks that we have been sending out of state, as she mentions, at great cost. And to me, it's just so untenable that we have to do that, and that folks who need that level of care and support at this point have to be that far separated. So I think this whole COVID crisis has obviously really underscored how difficult separation is. And so I just simply wanted to take a moment to sort of underline her comment. I think that I didn't hear that in your final summary, but that's not to say it's not in there, and I just wanted to speak to it.
No, I appreciate that you brought that up, Joni, and I'm wondering if that speaks to making that issue its own recommendation. So, Anne, you were getting ready to say something too.
I was going to say, we also talked about adding in number 2 a stronger statement about the funding needs. I went back and I looked at the raw data that we got from the survey as to where an in-state neurobehavioral program landed. And hang on a second. So in the category for crisis management, the things that folks rated were community-based intensive services, neurobehavioral treatment, crisis supports, and other. And neurobehavioral treatment was just slightly behind community-based intensive services. I think we can absolutely include a statement about neurobehavioral treatment. And I do think that the preference for community-based services reflects the desire that we be able to handle these folks outside of an institution. So neurobehavioral really does point to the institutional need, while the community-based services speak to what we might be able to do without having to put somebody in an institution. So that's an easy addition to make since it was the number 2.
So what we're talking about then is including the neurobehavioral supports in part of number 1, in-state neurobehavioral. Expanding a little bit on item number 2 and leaving item number 3 as is. Is there anyone that would like to respond to that though? Before we talk about process.
So this is Kevin Kojo. I know I'm a minority viewpoint on this, but I just did want to mention again my comments earlier about that. I think that the purpose and the intent of this third recommendation for connecting CSB, substance abuse, mental health services providers to expertise in brain injury so that they can enhance their capacity. I think that's right on, but the mechanism here for me is problematic. So, if I had a recommendation to make, it would be to kind of reframe it to focus more on bringing the providers together and harnessing the expertise that's in this council and across the state in brain injury, allowing maybe for interagency collaboration underneath that. But, as it's stated, I'm probably minority, so I'll leave it there.
Kevin, would it be correct or incorrect to be labeling your approach as you catch more bees with honey? Is that a little bit about what you're saying?
I will leave that to the council to decide.
Okay. Go ahead, Joni.
Oh, nope, sorry. I was just responding without trying to say something proactively. I was just chuckling, sorry.
Any thoughts on what Kevin's proposing, or is the feeling that no, this is important and the language as written should stand?
I think I'm just having a hard time fully understanding what you're saying, Kevin. Sorry.
Yeah, no, it's no problem. So I guess within the scope of the council, a recommendation to get a state agency to comply with legislative language. I'm not sure I get how that can work. So my point is that I think that when I'm reading the text of the priority committee's recommendations, I mean, it makes a lot of sense to me that there needs to be attention to the way in which CSBs and providers who serve folks with substance abuse and mental health needs are also supported in supporting brain injury needs. So I mean, I think to me that's the thrust that my sense of the thrust of the recommendation, and I guess it's more of a matter of framing the recommendation as focusing on supporting collaborations like that rather than compliance with legislative language. So I think for me, it's a matter of, it's not really the purpose and the thrust of the recommendation. It's just sort of the mechanism that we're, that the way it's framed as a statement of basically recommending that DARS get another state agency to comply with that. So that's where I'm coming from. But I hope that everyone understands that it's not a matter of any concern with what I think is the thrust of what's trying to be done with it.
What I hear Kevin saying is something down the lines of, since this letter is going to the commissioner, as here are the priorities. And I'm going to be honest with you and say I'm on my phone, so I don't have my reading glasses on, so I can't read a thing that is on the screen. So I don't remember how it's worded, but something that would say down the lines of, we encourage DARS to look for ways that it can collaborate with DBHDS to ensure that blah, 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 blah is followed. And that proper reporting or adequate, I'm looking for the right word, but accurate reporting so that appropriate services can be in place. That's what I hear Kevin saying, just something that's less directive of make them comply, but more, all right, let's figure out how to work together to make this happen in a different, same thing, just different words.
I mean, I don't want to get us belabor this, but it's not really a matter of like it's I think there's a broader focus. I think there's a focus on, I mean, the reporting focus, the language in here about the need to bring providers together, the potential connection to innovative practices that are going on in Newport News and Virginia Beach. It seems to me that's where the meat of the recommendation is. What can we recommend to the commissioner to support those kinds of collaborations in a broader way? And as Gail was mentioning, it might involve interagency collaboration, but it might involve creating opportunities to bring providers together and connect the expertise of the council and others across the state to the providers with support from another agency. So that's kind of where I am on it, but I do realize that again, that may be a minority view, but that would be what I think is to maybe broaden the language a little and move it out of the compliance rhetoric that it has, as far as the mechanism within the scope of this group. But again, I want to be clear that my raising this issue is not in any, I hope you don't take that in any way that I'm not friendly to the thrust of the need for a lot of capacity building among providers across many need areas for understanding brain injury specifically. And I think there's a lot of expertise that can be leveraged for that. So.
Chris, can I make a comment? I think that taking the compliance piece out of it is really appropriate. I do think I have some concerns about a broader brush. In working with the Department of Behavioral Health over 15 years now, what I find is when you're fairly directive and they have one thing to do, they respond better because one person's in charge of it. If we go in there and we say we want to find different ways to collaborate with behavioral health, we're going to be shuttered, here and beyond, and everybody's going to pass the buck. So I sort of feel like we can take out the compliance language and say, let's figure out ways to collaborate. I wrote a note down here. Encourage DARS to find a way to work with behavioral health to accurately report the number of persons with brain injuries as stated in the General Assembly budget bill. So something like that, which says we still want this little piece of information, but we're not going to say you have to comply with it because there's a legislative precedent and it is fairly directive. And we've been trying to get an answer just on this, Kevin, for 5 years. Just on this one thing for 5 years.
Yeah,
And Anne and Kevin, I appreciate both of your comments, and that's kind of why I came down a little maybe more heavy-handed on it, because I know, Anne, you've been on multiple work groups with Department of Behavioral Health around this issue, as have I, over the past 5 years, and yeah, that whole collaborative approach is nice, but it hasn't really gotten us anywhere. And there was a reason we went and asked them to do this, added this into budget language to make them do this, because we were asking them before for these numbers and they weren't doing it either. So I personally don't mind, and it's up to the decision of this committee to being a little bit more directive of it. It is a directive of theirs that it benefits, that gives us information on our community that and they haven't been complying with it. So I think we can be a little bit more directive now. That's my 2 cents on it, but I understand everyone else's viewpoint on it as well, and I'm fine with whatever the language is.
And I wanted to say one more thing, and I guess I was focusing more on the second part of the recommendation around provider capacity building and expertise, as opposed to the reporting requirement. But
you're feeling there could be pushback with providing services, is what you're saying? Saying that you have to comply with providing those services? That's the second point, right?
Well, the second part of the recommendation is, I'm reading, as I understand kind of the justification. So, I'm going to defer to people who are much more expert at the history, Ann and Jason and others. So I don't want to get too far afield, but I guess what I see as reading this is that the idea of getting data is really important, but there are multiple parts to the recommendation. So there's the data part, which I was sort of mentioning that in terms of recommending that another agency comply with data reporting requirements, I think is tricky for me to get to in the scope of this, but again, I might be a minority viewpoint. There's also another section of the justification that talks a lot about it maybe implying that once you have accurate data, you're able to see the need for availing mental health and substance abuse, so availing CSBs and providers of resources to help them work effectively with people who have mental health, substance abuse disorders, and also have brain injuries. To me, that is where the thrust of the recommendation is like making services better, enhancing the community-based services that are provided, and so forth. And so maybe there's just a lot chopped in there, and I'm focusing on one part at the expense of another. And I certainly don't want to underestimate the frustration of getting good data. But I'm also thinking about where I come from in terms of feasibility within this scope. So I'm going to leave it there, and I will accept forgiveness if I.
I want to just offer this. I mean, Ann has put forward some good compliance, some good not compliance, some good language that we might use instead. And Kevin, a little bit what I'm getting from you is that should we show why this would be valuable instead of just compliance for compliance reasons, that we want to show that this would be the benefit to people with brain injury of doing that. Would that be accurate, Kevin?
For me, I think that's a step forward. I mean, I think that's the language would be important. And again, there are lots of other voices here, so I think that it'd be great to hear that perspective. But I mean, I think you guys kind of know where I am on it, and I do think that maybe taking the focus off of DBHDS, for example, and putting it into a broader frame that could encompass some interagency collaboration, but get at what I see the purpose is to enhance capacity. And I kind of, I mentioned supporting collaborations, but that I think that level of breadth would be appropriate here, but I do understand that there are others who, there's a history that that others have more expertise.
I think we are hearing from the brain injury services providers that this is an important issue, that they worked hard to get into there. So I do think it's important to include that focus on it. So I'm wondering, as we go forward,
Chris, I just wanted to, Kevin's further explanation there. I understand exactly what he's saying now. There really is two pieces to number 3. One of them is complying and giving us the report that they're supposed to be given to us. And that, to me, like, to be blunt, like, they should have been doing that all along. Do it. But then I think to Kevin's point, and Kevin, I don't want to, hopefully I'm summarizing this correct. The second half of that recommendation is about how we need to work collaboratively with the Department of Behavioral Health in developing services and resources for folks with brain injury who have co-occurring conditions. And that, I agree, is very much a collaborative exercise. We just can't say comply with that. That's not really going to get us anywhere. So maybe we can kind of separate those two out. There is a compliance portion, in terms of get us the report that you're supposed to get us. But then there's also this more collaborative part that we need to do.
Jason?
Yeah.
Jason, I apologize. We're going to have to stop a second. For the captioning has stopped and it's gone back into the chat box, and we have to get it back into the public view.
Okay.
I apologize.
That's all right.
There we go. It's back in the public view. Okay, it's back.
Next time, Donna, just go ahead and put that in chat to me so that I can, all right? If it happens again, just type to me in chat. Keep going, Jason.
No, that was about it. I think what we could do is separate those two out. There's a compliance, right? Do the report on the number of folks with brain injury within your service system as you're asked to do. But then there's this bigger piece of how persons with brain injury are served within your system, and that does require a much more collaborative outreach and continually working with the Department of Behavioral Health on. I mean, that's just not something that we could just tell them just to do. I mean, that's a much bigger question that we're asking, or a much bigger issue that we're trying to get in terms of, well-rounded services for our population within their service system.
Yeah, I think just being in the system, I will say that with the compliance issue, I think just the directive will be the most effective thing, because it very much is a system where if, yes, there's going to be grumbling, but if you're told you have to do something, it just gets added on. And so I think there is that issue of kind of just the reminder that this is something that needs to be done, and at this point needs to be addressed. We are rolling out a new electronic medical record. So this actually is probably an opportune time that it could be something that is added into all of the information that's there now, or the templated screening type sheets that we're having to use with the medical record. So that could be, this could be a good opportunity for that. And then the other side of it, in terms of provision of services, I think that people could get the understanding that this would be very, very much to our benefit to have this data at this point, because we are seeing more and more folks with brain injury that just from the mental health inpatient side that we don't feel should be there, but we have nowhere else to put them. And we have folks that right now we are waiting to try and get people up to Massachusetts, which, they got sent back from Massachusetts and the family was happy to have them closer. And we're having to say, we're sorry, we're gonna have to send him back. Meanwhile, we're not really equipped to, we don't really have the expertise on staff necessarily to provide the services that these individuals need and the types of interventions that will be most beneficial to them. And so we are essentially managing people that should be, we shouldn't be managing, that we should be supporting. So, so I think that people will see it as something that can be of benefit to us if we have, so I see the idea of linking them together. I also see the purpose of kind of separating them, but I think kind of them being together will help clue people in, like, well, you want to get these numbers because you're kind of saying we don't know what to do with these individuals, but you don't really have the numbers to support it. So it's all anecdotal. But if we can kind of capture the numbers and then say, we're also talking about acuity going up. We're also talking about straining of our resources. How many times is this kind of where those problems are arising, to really force the conversation? So I agree with you, Kevin. I just think that there are, I don't know what folks think of that, if it's kind of the arm twist, or if we do want them separated.
Well, I think as the chair of the committee, there's a little clarification that I'd like. So the way that number 3 is written now, it's really just about data. That's all. If we think that there needs to be a 4th recommendation on building provider capacity, we can tackle that. But I don't know that building, the way that the recommendation is currently written, which says, work with them to comply with requirements from the budget bill, which include, an annual report with the community services boards. That's who's doing the substance use disorders and mental health and, the state mental hospitals too. So it seems to me like we're trying to put 2 things in the same recommendation. We can soften the language about compliance and say, we need accurate data. And we just do. The CSBs aren't collecting anything. They're not screening for brain injury at all. But we could also do something about building provider capacity. We tried to tackle that in the last year when we did the CSB Roadshow, and we did 12 4-hour trainings at the CSBs, and we'd be happy to build on that as a provider capacity. We could talk about what's happening at Eastern State with the work that they're doing with some of these folks and ways that we're building capacity and a continued investment in that. But I don't know. I mean, it seems to me like we're almost talking about 2 different things in number 3 instead of just one. And I'd like a little clarification around that as I write the letter.
Yeah. So Kevin, before you talk, I just want to say one thing real quick, if that's okay. A little bit what I'm wondering about is these priorities are a 1-year focus. And it is really hard to whittle things down and to say, we're saying to you, Commissioner, and to DARS, these are the priorities we ask you to keep in the back of your mind for the coming year. After our next agenda item, or one of our next agenda items, is to start talking about using the priorities letter as well as the issues that came up through this whole process to develop a multi-year state plan for brain injury. So I want us, as Kevin, as you're getting ready to respond, and as people are thinking about what Ann just introduced into the conversation, I would encourage you to be thinking about, what do you want in your 2021 priorities letter, and what is best served in a multi-year plan that we would then be rolling out. So sorry, Kevin, go ahead.
No, and yeah, I just wanted to respond to that. I mean, just to clarify, I'm referring to, on the second page of the priorities summary, it's referencing a budget bill from 2015, and there are 3 parts to that bill that's the reference point for this. And one of them is the data, and 2 of them have to do, as I mentioned, with, it appears, including individuals with, brain injury and co-occurring disorders in treatment and support services. So that's kind of where I was drawing off of that. And I guess I would just say again, if the recommendation is to support accurate data collection, that's a recommendation. It's just the mechanism of recommending that an agency comply with legislative mandate through this process. So, and you know, I'm fine to be a minority view. It's okay, as long as you guys will keep talking to me.
So I want to move us, it is 3:15 now. Who thought we would still be talking about this at this point in time? But I'm glad that there is discussion. What I want to suggest is, based on the amount of conversation about the language in the priorities letter, would be how you feel about the priorities committee reconvening, taking into account all of this feedback, developing a draft letter and submitting it back to you to vote on. I also, just so that it's in the record, I want to just read for you because Mike had to leave. And Mike said he has to step away. He fully supports the changes proposed to parts 1 and 2 of the priorities letter. He also agrees with changing number 3 to ensure state agencies report the data they're supposed to be reporting out. Without compliance, we are missing opportunities that gather critical information that can help individual TBIs, and also request funding for resources we desperately need for survivors. I feel strongly that we bring Virginians back to their home state who require resources we do not have available here in Virginia. Sending Virginians away along with Virginia taxpayer funds to another state is unacceptable, so I fully support this being top priority of the council and DARS. And if the council so decided, he would also support adding a 4th priority. So I just want to make sure that that's in there for the record.
Chris, did you also see that Barbara
did.
Seymour had a comment? Okay.
Yeah,
Thank you.
Barbara just said she had to leave. So is there a recommendation from someone on how we move forward from here? And if you wanted to put it in the form of a motion, that would be lovely too.
Chris, I like your recommendation that the priorities committee kind of revisit all the feedback and come back and then write a draft letter that the council can then subsequently review the draft letter.
Jason, is that a motion?
I can make that a motion, yes.
A second.
Monique second that?
Yes.
Okay, Monique, I'm going to run down then with a roll call vote, if that's okay with you.
Yes, thank you.
Can I ask a clarifying question? Would we
Sure.
would we then vote on that revision? Would we make amendments to it and then vote electronically?
Yes, the final version would go out to all council, and yes, there would be an electronic vote.
Okay, thank you.
No, thank you for asking that.
I will say, just so everybody knows, we are on something of a timeline with getting this letter to the commissioner. What we've been asked to do is to get this letter in the hands of the commissioner in August in preparation for budget development for FY22. So we'll send the letter out and we may be able to take some tweaks, but we can't necessarily open it up for a great big comment fest again because we're under a little bit of a deadline. I just wanted to make sure everybody was aware of that.
Comment fest, Anne. Do we get t-shirts? That's what I want to know. So we have a motion and we have a second. I am going to go through the checklist, and what I'll need you to do when I call your name, please unmute and say yes or no to the motion that's on the table, that the priorities committee will use the feedback to develop a revised priorities letter that will go out to the council for a vote. Monique?
Yes.
Yes.
I agree.
Okay. Mark Bender?
Yes, I agree.
Thank you, Mark. Cara Mexner?
Yes, I agree.
Mike had to step off. John Heath? John, are you still with us?
He had another meeting at 3 and had to step off.
Thank you. Cara Beatty?
Yes, I agree.
Thank you. And I probably said your name wrong too. So John Reynolds?
Yes.
Thank you. Sandy Parker.
Yes.
Thank you. Cynthia Jarmell.
Yes.
Okay. Nick Redisil.
Yes.
Thank you, Nick. Carson Ward. Okay. Victoria Newman.
Yes.
Thank you, Victoria. Ann McDonald.
You probably need that out loud. Yes.
Yes, thank you. Jason Young.
Yes.
Thank you. Susan Moon.
Yes.
Thank you for your vote, Susan. Jean Hoyt.
Yes.
Thank you. Gail Brunk.
Yes.
Thank you, Gail. Chris Miller, I will vote yes. Deborah Johnson.
Yes. Yes.
Okay, great. Thank you. Thank you. Jenny Marwitz.
Yes.
Kevin.
Yes.
Thank you. Joni Latimer.
Yes.
Maria Stransky.
Yes.
Barbara had to step off. Barbara Seymour. Elizabeth Horn.
Yes.
Thank you. And George Worthington.
Yes.
Thank you. Thank you all also for staying with this and for being a part of this. Monique, if it's all right with you, I'm just going to jump right into the next agenda item.
Sounds good. Thank you.
So there are two other things that we wanted to bring up to you today for business. The first is, as I just referenced a little bit ago, that one of the things that we need and want to do, in part because it is a deliverable for our federal TBI grant, but also because it's good practice, is that we need to develop our state plan for brain injury. In the past, that has been sometimes a one-year plan, but we really felt that this year that we needed to be focusing on a multi-year plan that will give us our roadmap or the strategic plan that any organization needs to go forward. So, how do you know how you're doing if you don't know where it is that you're going? So we will use both the priorities that made it into the priorities letter, but also the other feedback that's been collected to work on developing that plan. So there is currently a committee. I don't know if you all remember in January of this year, which feels very, very, very long ago. I think it was about 3 years ago. It was January. So the state plan review is Ann McDonald as the chair, Cara Mexner as the on that committee, George Worthington on that committee. I'm hoping that the three of you would still be willing to be on that committee, but I also wanted to offer, would anyone else like to be on the state plan, developing the plan committee? Don't everyone unmute at once.
Gail.
Gail,
Chris, it's Gail. I'm not volunteering, but I have a question.
Sure.
And I'm, well, I know who two of those people are. I'm going to make a statement and then I'm going to walk away from it. I think it is critical that if we do not have a survivor on that plan committee, we should. I'll leave it at that. Rather than me saying, I don't know if anybody is. So that's my statement.
Great point, Ian, Gail. And we do need a survivor on that.
This is Victoria. I was actually in the process of unmuting before she came in. So yes, I'd love to volunteer.
Thank you. Would anyone else like to be on this committee or work group? Okay. We will be talking to you soon then about convening, and as soon as the priorities letter is done being written. So the other work that the committee has to do is that in July, it is typically the time when the nominations committee starts to convene to look at developing a slate for the council to review that then goes to the commissioner for appointment. we have two people that actually will be leaving, their terms will be ending next March. Two folks that have been here a long time and have contributed a great deal to the brain injury community, and that would be John Heath and Mark Bender. So we'll be talking more about how we say thank you and stay in touch for those two. So we know that those are two positions that we'll need to fill. There are 4 individuals that are finishing their first terms, and so also will need to indicate if they want to be considered for reappointment or not for the Nominations and Elections Committee to address. And that would be Cara Mexner, Mike Puglia, Nick Redisil, and Carson Ward. So depending on those folks can ask to be reconsidered, and the Nominations Committee would consider their requests. The Nominations Committee needs to have a slate to the council to review by January of 2021. So I am looking for individuals who are interested in being on the Nominations and Elections Committee. And so Gail, so that Gail doesn't have to say it again, every committee on the Brain Injury Council does need to have at least one survivor on it. So is anyone interested in being on the Nominations Committee?
Yeah, sorry, go.
Wonderful. Thank you, Nick.
Yep. All right.
Is anyone else interested? We're going to need a few more people.
I will be on the committee.
Well, thank you, Monique. Now, Barbara Seymour and Susan Moon, you both were on last year, and you did a really great job.
I was just coming off mute. This is Susan Moon. I'll stay on.
Thank you. Would any one of our new members like to join this as a nice way to jump in and get involved?
I will. I'm still learning. This is my first meeting, so I feel like I'm going in blind, but sure, I will.
That's okay. This is a great, you'd be on a committee with a great group of people to be working with. Wonderful. If anyone else decides driving home today, you know, I really missed the opportunity. I want to be on that committee. Just feel free to drop me a note. So that is the official business that we need to do today. At the October meeting, we will be looking from the existing members that will be going through next year, and looking at also developing a slate of officers, but that is from the existing council membership, not from the newly elected council members that will be on next year. So our last piece of business then, is there anything that anyone here would like to bring up or address? Okay, in the absence of not seeing anyone unmuting, I want to say thank you all for your great input today, as well as for your support of DARS, and especially for people with brain injury. A big thank you to the people on the Priorities Committee, and you have not necessarily seen how hard Donna is working behind the scenes. So a big thank you to Donna for all that work. And we look forward in getting a good priorities letter out to you for vote. Have a great Friday afternoon, folks.
Thank you, you too.
Bye-bye, everyone.
Thank
Thanks, everyone.
Thank you.
Thank you.
Hey, George Worthington, it's David
Thank you.
McKenzie. Could you call me real quick?
Will do.